Yeah, fantastic point, because I think as rheumatologists, sometimes we rush to think about imaging, and it really does start by palpating the pulses, both the radial and ulnar pulses. And you can do what's called an Allen's test, where the patient makes a fist, and then you're occluding the ulnar and radial pulses, they release, and you can see that palmar surface being very white. And then you release the radial pulse, and the blood flow should return quickly within 5 seconds. And you can repeat that with the ulnar circulation. So by doing that physical exam maneuver, you can get an idea of the macro circulation, or the larger vessels. And then if you turn the hand over and you look at the nail folds, you can get of the microcirculation. So both palpating pulses and looking at the nail folds can be a great place to start when someone has a digital lesion. It's really important when you're assessing a patient with digital ischemia to first start with, do they carry a rheumatic diagnosis already? And so in that case, there's certain autoantibodies, of course, that are associated with digital lesions, and then you would expect it's underlying disease. For instance, if a person has known scleroderma and you know that they have a scleroderma-specific autoantibody and they have a digital ulcer, that would fit in with what we know about scleroderma. Now, I think that the important thing is, if you're seeing a patient for the very first time, that you do document all of the serologies to try to figure out what autoimmune disease is associated with. And importantly, if particularly if someone's inpatient, you want to make sure you're taking a good history, and have they had a surgical procedure, as they're concerned for underlying endocarditis or infection. Those other comorbidities in that patient become important for understanding how you're going to treat the patient. Yes, thank you. That is, I think, the most important part of a rheumatologist's job in management. So it's important to ask every new patient that has an assessment with rheumatology about Raynaud's phenomenon. And that has two components, really. The first is just asking questions. What do your fingers do when they're cold? And if the patient mentions that they change colors, at that point, you're going to show the patient a picture of Raynaud's phenomenon and get information on whether they see a demarcation line, whether the Raynaud's phenomenon also occurs in response to stress, and whether they, in addition to having finger symptoms, have nose or toes or ear symptoms when they're exposed to cold. That can really help you understand if they have Raynaud's phenomenon, and if they do, then you're of course going to do that nail fold capillaroscopy to confirm whether it's related to rheumatic disease. Once you've made that diagnosis, it's essential to start vasodilators if their blood pressure will allow, to improve perfusion to their fingers. And we know when you give blood flow medications to the patient, their symptoms should improve. But we can also see improvement in capillary nail pit changes. And more importantly, if you can prevent the dropout of capillaries, you could be preventing a digital ulcer. So again, the key for preventing critical digital ischemia or a digital ulcer is asking about Raynaud's and getting patients on prompt treatment, particularly if they have nail fold changes that are alarming. Another great question. So the key place to start is whether they have reversible ischemia, or in critical digital ischemias when they're not getting any blood flow to the finger, and so it's almost like a heart attack of the finger. So you're going to want to act quite promptly if the finger is pale and not receiving any blood flow, and there's some signs of early gangrene. If it's the former, so a patient has the beginning of a digital ulcer or just severe Raynaud's phenomenon, the first line treatment is a calcium channel blocker, and you're going to titrate that medication as to blood pressure, and keeping in mind that patients can get edema or swelling in their legs or hands, so getting in compression gloves or compression hose while you're titrating can sometimes allow you to achieve a higher dose. I'm going to comment on the compression gloves. Those are best done with an occupational therapist, so they're not too tight. Once you've gotten your calcium channel blocker to the appropriate dose, if the patient's still having symptoms, you'll oftentimes add a phosphodiesterase inhibitor, and that medication is usually your first go-to if someone has an active ulcer. So Raynaud's you get more aggressive if they have an ulcer present. If you're using a calcium channel blocker with a phosphodiesterase inhibitor, you again really want to educate the patient that they can get quite a bit of lower extremity edema. So you want to slowly titrate that phosphodiesterase inhibitor if you have background calcium channel blocker therapy on. Now, for critical digital ischemia, where it's more urgent, that patient may need to be admitted to the hospital. And in the hospital, you are going to work with your pulmonary hypertension experts to get access to a prostacyclin analog. And that's those medications, it's important to realize, are off-label for use in critical digital ischemia. So you're going to want to ensure that you can get access to the medication. Oftentimes, the hospital formularies may not release the medication if it's not going to be paid for. And you need to figure out whether you are going to give that medication in the ICU setting because of the titration that's needed. So the urgency is really dictated by the appearance of the finger, and that again really underscores, ideally, in the case of Raynaud's phenomenon, everybody is on a therapeutic treatment. Yeah, I think some of the key for moving therapeutics forwards is there is a new questionnaire that was published last year called the ASRAP by the Scleroderma Clinical Trials Consortium that allows us, certainly in a short 10-item question bank, to ask questions that get at the patient's symptoms so that you can use your medications or titrate them to meaningful outcomes. The reason this is such an advancement is prior to the ASRAP questionnaire, the main way we assessed how a patient was doing on therapeutics was using a Raynaud's condition score, which is a diary-based instrument. And this diary-based instrument just hasn't performed well in clinical trials, and that's why there's really no FDA-approved drugs for Raynaud's. We just didn't have a good outcome measure. So I think it is very exciting to have an outcome measure now that works. The other thing I think is exciting diagnostically is the cost of nephrocatheteroscopy devices is significantly reduced, allowing investigators as well as clinicians to use these devices for capillaroscopy assessment more routinely rather than just in the research setting. So you can bedside really evaluate effectively how your Raynaud's treatment is going. And I think with these two, but having both a patient-reported outcome as well as a measurement tool, we can now more effectively gauge response to therapeutics. And there are, of course, a lot of therapeutics that are hopefully coming down the pipeline for testing in prevention of digital ulcers as well as treatment of critical digital ischemia. Yeah, I think one thing that's really important as a rheumatologist is to know who your care team is before you see the problem. So what I mean by that is oftentimes as a rheumatologist, we're waiting till the patient comes into the clinic with a digital ulcer or a sore. If you know your access to therapeutics, so you're aware of how you can get your patients a phosphodiesterase inhibitor, such as using a GoodRx application on their phone and not going through the insurance company. You know who your best wound care specialist is and how fast they can get the patient in. You know who your occupational therapist is who can help you with some adaptive devices and protection of that wound. And if you know who your best surgeons are who are willing to follow that lesion with you without taking the patient right to the operating room. All of that information ahead of time can really help you effectively deal in the clinic setting with a patient acutely. I think sometimes it's hard to coordinate everything on the back end, but on the forward-facing end, really getting a good understanding of what your resources are locally for treatment and prevention is a real critical part. And yeah, one of the things we've tried to do is integrate just image upload in the consult request. So just meeting with your medical record, seeing if when someone asks you to see a patient with a digital lesion, whether you can get a picture of that image to you quicker, allows you to know, does that patient need to be admitted to the inpatient service, or is this an appropriate outpatient referral?